This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning, we have our own Dr. Khusrow Niazi. He's going to speak to us about an update in peripheral vascular disease. Khusrow received his initial training in Pakistan and has been several places throughout the U.S., sort of spanned the continent, has been here at Emory since 2003, and is currently an associate professor in the division and heads up our peripheral intervention activities, and he's going to give us an update on PVD.
Thank you, Bob. Good morning. My goal is to see if I can get you interested in peripheral vascular disease, and hopefully I can get you to start looking at your patients beyond the heart. Trying to give you an update what's happened since my last talk, which was in February 2012. Mainly be talking about arterial and venous disease. Just a quick statement about carotid stenting. Not much have changed other than that the societies have started fighting much more vigorously among themselves and to decide which way to go with carotid stenting. It's unfortunate. The science has been relegated to the sidelines, and so the CMS and Medicare is enjoying that because they don't have to reimburse that unless the patients are in trial. We are in a trial where we can do carotid stenting even in low-risk patients. Before, carotid stenting was just in high risk. Unfortunately, that trial is finishing its enrollment. They need 840 patients, and I think 790 have been done, so we don't know what will happen after that. But basically, talking about peripheral vascular disease, I'm going to split my talk into arterial and venous over here, and hopefully can make you aware of the prevalence of this disease and the serious consequences when the disease does not get diagnosed, or when it gets diagnosed but much later in life in patients, and they develop an ominous problem called critical limb ischemia, which then portends a poor prognosis down the road. And what are current challenges in the treatment of peripheral vascular disease? If you look at the prevalence of this disease, it's phenomenal. I mean, if you just look at PVD consists of peripheral arterial disease and venous disease. If you look at the venous disease, peripheral arterial disease, and stroke, they encompass a large part of vascular disease, as when we compare it to coronary artery disease or congestive heart failure or stroke or even heart valve disease. So a lot of our patients are going to have these problems, but the issue becomes is, as cardiovascular specialists, are we willing to recognize these in our patients? Or even ask them, because you'll be amazed that a lot of this diagnosis can just be made by history taking in a few minutes' time. So this peripheral arterial disease is really a disease that progresses as people get older and seen more commonly in patients. Also, people have quoted that somewhere between 8 to 12 million people in the United States are estimated to have peripheral arterial disease. And it's not just limited to the United States, it's worldwide, as I've seen it when I've traveled around and given talks and operated on patients in other countries. And carries a higher risk for cardiovascular mortality. And the annual mortality is somewhere around 4 to 6%, but as people get older and they have developed the disease when they were in their 50s, the mortality goes up as time passes, and the prevalence has been shown to be somewhat higher in men than in women. It's interesting when we look at peripheral arterial disease that it is the prevalence is greater than congestive heart failure or stroke. Though congestive heart failure and stroke does have more serious sequelae, but you'll be surprised when I discussed with you when peripheral arterial disease gets undiagnosed, the serious sequelae these patients suffer and the morbidity that is associated with that. And critical limb ischemia, which is a part that I really have seen a lot and feel sorry for those patients when they get missed. Their prognosis is poor, especially I think when you tell a patient that your limb will have to come off. I think it's a very depressing news for the patient. And half of those patients will not be living after an amputation in 4 years' time. The big thing that I noticed with peripheral arterial disease is the marked reduction in functional capacity, and that is my first clue that when I'm seeing patients, if I see them walking with a cane or a walker, or if they're walking just slowly, I will get an ABI because the physical diagnosis is just not accurate. And it's such a simple test with no risk involved in it. And its sensitivity and specificity is so good that I think it should be utilized much more commonly. The problem had been in the past the appropriate type of machines to become available, but I think now we have the technology, and in fact we will be doing a prospective screening of a new type of machine which will make the job even easier in 5 minutes, where small cuffs can be placed on the big toe and on the thumb, and you press a button and the laptop will be able to calculate an ABI in those patients in 5 minutes time. And obviously these patients, they die because of cardiovascular events that take place in patients with PAD. And as we all know, atherosclerosis is not limited to coronary artery disease. It is really extensive from head to toes. The diagnosis of PAD is really mainly by history. There are very few times that the clinical examination will help us, but most of the time, by 90%, I would say, you can diagnose it. Occasionally, I've had patients where I cannot decipher from their history, is it arterial, is it venous, and you touch the limb and it's cold, and that helps you guide which way to go. Ankle brachial index, and we'll talk about that because I think that plays a very pivotal role in the diagnosis of peripheral arterial disease, and that duplex ultrasonography and diagnostic testing, we'll talk about that. In 2001, very interesting study was done because there were physicians like me who believed that peripheral arterial disease is very extensive. So they did a trial called Partners and published it in JAMA in 2001. Basically what they did was they sat outside primary care physicians' offices. And anybody coming out of those offices after they had seen the primary care doctor, if they were above the age of 50 and smoker, or if they were above the age of 50 or diabetic, or if they were just above the age of 70, if they fell into any one of these categories, they did an ABI to identify do they have PAD or not and what their symptoms are. And it was amazing that half of these patients did not have symptoms. And part of the reason why they don't have symptoms is because the disease comes on so slowly that these patients alter their lifestyle. So they become more and more sedentary. So when people say, well, why are you opening up a 90% SFA? Because the patient is asymptomatic, and I will basically tell them, you put them on a treadmill and walk them at a normal speed, they will become symptomatic. So asymptomatic doesn't mean they really don't have symptoms. It's just that they've altered their lifestyle and they become more and more sedentary. And then many of these symptoms that we have classified in the past as neuropathic, that is tingling, numbness, burning in the feet, and we just relegate as soon as the patient says, oh, that's due to your diabetes, and that has got nothing to do with vascular. But nerves need blood supply. So studies have shown that when you improve circulation, these symptoms do improve in these patients. And then the intermittent claudication that we look for as a diagnosis for peripheral arterial disease is only present in a very small minority of patients. We can miss the diagnosis of PAD if we just go by intermittent claudication. So when I see a patient and they complain of any leg discomfort, whether it's leg or hip discomfort, I quickly start thinking into these categories. Is it arterial? Is it venous? Is it something else? And that something else many times is spinal stenosis or degenerative spine disease. And that is very easy to separate on history taking. You all are aware of the risk factors, and I think diabetes plays a pivotal role. And unfortunately, as diabetes is becoming more and more identified in the patient population with obesity, I think we are going to see more and more peripheral arterial disease, especially when the patients are getting older. We are going to see this thing. Smoking, and I personally think that renal insufficiency plays also. These patients become silent. For some reason, they don't complain of their peripheral arterial disease. They are so focused every other day going for dialysis, they just don't think about arterial disease. And unfortunately, they are sent to us when they have gangrene already set into their toes and becomes too late over there. But as I said, age is going to be big because we are going to see more and more people as they get older. They are going to come back and be diagnosed with peripheral arterial disease. So what's the prevalence and epidemiology of this thing? It's best identified as the Rutherford-Becker classification, which was designed to help, just like with angina and coronary artery disease, to classify these patients, how their symptoms are. If they have intermittent claudication, that is, if they have any leg discomfort, that gets graded into 1, 2, or 3. So 1 is mild and 3 is severe claudication. If they have pain at rest, which is a bad sign because that means when they elevate their leg up, they start getting pain. That means they have severe disease and they are dependent on gravity to get the blood flow to their foot, which is a bad sign. And obviously if they have ulceration or gangrene. These last 3 categories comprises the critical limb ischemia, which carries a very ominous prognosis in these patients. And as I already stressed, that the reduced function and exercise capacity makes the disease even worse in these patients. So if we are seeking a history of intermittent claudication as the sign to diagnose PAD, we will miss a lot of patients. If you have patients who have got coronary artery disease or any atherosclerotic disease that you have diagnosed in any vascular bed, I think you should think of PAD, and getting an ankle brachial index is not too difficult. Normally in the past, the ABI had been defined as abnormal when it was less than 0.9. More recent papers have come out and they have said that even when it's less than 1.0, patients' risk of developing PAD is higher and their prognosis gets worse. And lower the ABI, the more severe the PAD is. This is looking at patients who came in and had ABI when it was less than 1.0, and you can see that the mortality increased once it drops below 1.0. So really 0.9 is not the cutoff, but still it is being used in the vascular literature. When the ABI is greater than 1.3 and some study says 1.4, that implies that there is calcification of the vessels in the foot. So the anterior tibial or the posterior tibial arteries are calcified. And when you inflate the cuff, you cannot occlude it. So the pressure will be very high. So when you do the ankle divided by the brachial, your ABI will come back greater than 1.4 or 1.3, and then it becomes non-diagnostic. But studies have also shown that these patients who have non-diagnostic ABIs, which happens in about 5 to 10% of the population in general when you're doing ABIs, that those patients also have high mortality because calcification in these vessel walls means that they have atherosclerosis. But the test is not definitive for PAD at that time. So I will get calls, physicians who start doing ABIs that if I have an abnormal ABI, what should we do? And this is in my practice what we do. And in the literature, it's also been shown by Hyatt, they follow a similar pattern, but a little bit different in diagnosing it. If it's less than 0.7, they have definitive, unless there was an error in doing an ABI, which really should not happen. But if you have an error, then this algorithm won't work. But if you have less than 0.7, you have definite PAD. There's no doubt in those patients. And this is at rest. However, when we are doing ABIs in the vascular lab, we are also looking at arterial waveforms. So that's how we know that the ABI was done correctly or not. Because when you have an ABI less than 0.7, your arterial waveforms will change, and I will show that in the next slide. My test of choice, if the ABI is less than 0.7, is an MRA. The iodine contrast is not, the radiation is not there, and you get beautiful pictures all the way down to the ankle looking at the small vessels, and you can diagnose easily. And then we have this nice relationship set up with the MRA people that they will send me the pictures in the email, and I can show them to the patients and the families in the clinic. And that has such an impact when they see the arteries just cut off or is severely stenotic. CTA can be done in certain places. Many private large physician groups have placed CTAs in their offices, so they start using those CTAs. But I personally think CTA, you have to do iodine contrast, and there's a certain amount of radiation with that. Arterial duplex is an older test that has been done for past 60 years, but it is really technician dependent, and its accuracy starts dropping down once you get down below the knee because the vessels become small, and if the technician is not good, you can miss peripheral arterial disease. If your test ABI comes back at rest somewhere between 0.7 to 1.3, do an exercise ABI. You don't need to do an exercise ABI when it's 0.7. It's going to plummet. And unless it's a study protocol or something like that, you know that you have diagnosed the PAD. But when it's 0.7 to 1.3, you really want to assess how bad is the PAD. And if you do an exercise ABI and it plummets less than 0.7, then you can follow this algorithm over there. However, if the exercise ABI stays somewhere around 0.7 to 0.8, they have peripheral arterial disease, but it may not be that severe. The only time I get worried over here is if they have proximal iliac artery disease. Because in proximal iliac artery disease, you develop so good collaterals that the foot pressures are almost normalized. So your ABI may not give you an exact reflection. So if the patient is complaining of buttock discomfort or thigh discomfort, or if they have erectile dysfunction and they have an ABI of somewhere around 0.7, 0.8, I will investigate the iliac arteries at that point. But generally, if your post-exercise ABI is 0.7 to 0.8, they probably don't have severe peripheral arterial disease. At that point, checking their history, do they have significant discomfort or limitation? And if they have that, then you can consider less invasive testing, something like arterial duplex. Or if you are really concerned because the pain is severe and they are limited with the physical activities, you can go to an MRA, which will define the anatomy very nicely. If their symptoms are mild, you can just repeat the ABI in a year's time because the disease is progressive and the numbers should deteriorate over the next 12 months or so. If the ABI stays greater than 0.8, exercise ABI, but is less than 1.0, repeat it in a year because they have the diagnosis of PAD. And this is a nice non-invasive way of following these patients because when the disease gets worse, the ABI will get worse in those patients. When the ABI is greater than 1.3, some people say 1.4, it's a non-diagnostic test, and you really need to do something else. And arterial duplex is the way that we go in the office because it's less expensive than an MRA and a CTA. Now, I talked about arterial waveforms. Most of the ABI machines that are portable or are small don't give this thing. They will just give you the pressures. With the Doppler, you're measuring the pressure in the brachial. You're going to take the higher brachial pressure because if there's a disparity between the two arm brachial pressures of more than 20 millimeters of mercury, they may have subclavian artery disease. And I strongly encourage physicians that on new patients, they should really check upper extremity pressures because in a year you will find 1 or 2 patients with significant disparity. And the patient doesn't know. The patient will just tell you, oh, don't check my pressure in this arm because my doctors have told me that that's not an accurate reading. And they just keep checking in the normal arm. But when we do ABIs, we also have a vascular probe. So we are looking at the Doppler waveforms. And a normal arterial waveform in the peripheral is triphasic. Nice, narrow waveform, brisk uprise, reversal, and then comes back. Once you start developing the PAD, the waveform will start getting blunted and broaden. There will be also loss of the triphasic waveform. And finally, once you see this type of waveform or this waveform, you know these patients have significant peripheral arterial disease. So if I see this waveform, this or this with a normal ABI, I assume that the ABI is falsely normal or it was calcified vessels that has not dropped down from 1.5 into the normal range of 1.2 or 1.1, but they have significant PAD. And somehow we have never been wrong. This test is far more reliable than an ABI. The problem is the vascular probe is a little bit more expensive, costs somewhere around $11,000 to $12,000. But most cardiologists have echo machine, and if they have a vascular probe, they can easily do this arterial waveform. Or if they're doing carotid duplex, they have a vascular probe already, and they can do ABIs. This has been shown a long time back that the all-cause mortality increases even in patients with asymptomatic large vessel PAD. So they're not talking of some small vessels in the feet. They're talking of large vessel like SFA or popliteal. And even if the patients are asymptomatic, their prognosis is worse. And they need to be identified and they need to be given a risk factor modification treatment. There are cardiologists who will try to screen patients or identify the risk category. If they fall in the 10 to 20% Framingham scale, they will do an ABI to give them a little more weight. Do they really have significant atherosclerosis or not? And they will do an ankle brachial index because as the ankle brachial index drops, the odds of having MI, stroke, or cardiovascular death goes up. So you can use an ABI in risk stratifying your patients. As you have already realized that I like the MRA, and the MRA I like because it really gives us nice crisp images. And this is a patient with an MRA with the aorta, the iliac arteries, you can see very nicely, the common femoral artery, profunda or the deep femoral artery, the superficial femoral artery. In this patient, the superficial femoral artery is 100% occluded down over here. And when we get these pictures in email, we can look them in 3-dimensional, we can spin them, and we can show it to them, to the patients, not just in one view. This is going down. This patient had an artificial knee, but you can see how if there was significant disease, let's say over here, you will see the disease also proximal and distal. But this is the popliteal artery over here, which then below the knee first gives off the anterior tibial artery, which goes laterally. So from the posterior compartment comes into the anterior compartment of the leg and continues as a tibioperoneal trunk. And the tibioperoneal trunk then divides into the peroneal, which stays in the center, and the posterior tibial artery, which goes around the medial malleolus and supplies the plantar arch. You can see extensive disease the patient has on the left side, and the only vessel you see is the anterior tibial artery over here, and which fills over here. You can not see rich collaterals when patients develop this extensive disease. And this is below the knee, the anterior tibial artery forming the dorsalis pedis artery in the front, the tibioperoneal trunk, the peroneal artery, and the posterior tibial artery. If you have patent posterior tibial and anterior tibial arteries, the peroneal artery usually stops above the ankle joint. But this is the big collateral. When these anterior tibial and posterior tibial arteries get occluded, then the peroneal artery will give collaterals just above the ankle and provides delta collaterals. This has become a very important source for us to access these arteries. We can stick the dorsalis pedis artery or the posterior tibial artery in the foot, and we can come retrograde and recanalize totally occluded vessels, and has made our job easier in recanalizing them when we come from below for some reason as compared to coming from above. So let's talk about the critical limb ischemia, because I think that plays a very important role in these patients when they don't get diagnosed by us in the clinics. And I've seen patients who have been going to their physicians, their primary care doctors, or their endocrinologists or cardiologists, and for years, and suddenly now they come in with a gangrene of a toe. So patients who have high-risk categories, they will develop peripheral arterial disease, could be localized disease, could be diffuse aortoiliac disease, and they may have symptoms which may be typical, intermittent claudication in a small percentage, but large number of patients may stay asymptomatic unless you ask them. And my favorite question is with the family members, that can they keep up with you while you're out with them in the malls or walking out? And if they can't keep up with you, to me that's a sign that they may be developing peripheral arterial disease. Again, neuropathy or burning or tingling or numbness in the feet can be a sign of peripheral arterial disease. And when this disease gets missed or progresses, it's going to lead, those lesions are going to become worse and the vessels are going to get totally occluded, which we know anywhere in the vascular bed, coronaries, or anywhere else in the body, once the vessel gets totally occluded, it becomes extremely challenging recanalizing these vessels, especially in the legs when the length of these vessels is so long. And then they develop intractable ischemia and ulceration, which is the critical limb ischemia component. Now, one of the things that people always thought was that that's the pattern they follow, that they will have first asymptomatic, then they will become claudicant, then the symptoms will get worse, and then they will develop critical limb ischemia. And studies have shown no. They can go from high-risk patients who have got no other signs or complaints of peripheral arterial disease, and suddenly they come in with gangrene of their toe because they had an ingrown toenail, or they bumped their toe, or the podiatrist tried to do some minor surgery, and now the wound is not healing. And that's the common story that I see in my clinic, is that patient will come in because for 4 to 5 months they have had a wound or an ulcer that hasn't become infected because the podiatrist is giving local wound care, but the wound isn't healing. I mean, the wound should not take 4 to 5 months to heal in a normal circulation. So patients can go directly from just having the risk factor limb ischemia, and that is the frightening part. Because in the past, patients used to say, well, why do you treat them early? They have just claudication. Why don't you just treat them medically? And they will do fine. Well, if you won't even diagnose the asymptomatic, you can end up with this critical limb ischemia in these patient population. So medical management in patients who are picked up early, I think treating their risk factors and encouraging them about smoking cessation, which is a challenging task by itself, and encouraging them to do exercise, which many of the patients will say, Doc, my leg hurts, I don't want to do exercise, and they will just refuse it. And when you recanalize them and the symptoms improve, then they are more amenable to doing the exercises. The problem is that all the studies that have shown that exercise works was supervised exercise. And with the healthcare funds being limited, getting supervised exercise to our patients at least 3 to 4 times a week becomes very challenging. The treatment is, basically surgical or endovascular, and we'll talk about that a little bit. But these days we can recanalize complex disease, which is completely occluded in these patients with different devices, and we'll talk about those. We have developed newer technology which has allowed us to treat the disease in an aggressive manner and reduce amputation. Because to me, telling a patient that the only treatment we have for you is by taking your leg off, I think is a very depressing news when you give that to our patients. So critical limb ischemia is like acute coronary syndrome, and is the end stage for peripheral arterial disease. Once they develop critical limb ischemia, it's probably going to be limb loss for these patients. However, with newer endovascular technologies, I think we can limit the amputations. If it's gangrene, they can have an amputation of that toe as long as we have established blood flow so the wound can heal. The incidence of critical limb ischemia in the United States is expected to increase significantly because of the people getting older and the disease seen in those patients. Within 1 year of being diagnosed with critical limb ischemia, the 25% will experience a major amputation. Major means below the knee or above the knee amputation. I'm not talking just one toe or transmetatarsal, those are minor amputations. And they will have a very high mortality rate. And close to a third of them amputees will face contralateral disease. It's amazing that I have seen patients who have come to me with wounds on one foot and the other leg is missing. And that was missing for the past 2 years, but nobody worked up the other leg. So the disease doesn't come in one leg. The disease is going to be in both sides, but nobody works them up for those other limb to preserve the other limb. I mean, a patient would prefer to have both legs, but if he can't have both, at least one, as compared to having no legs. And the problem is, once the patient develops critical limb ischemia, the favorable anatomy is not present there for endovascular and especially for bypass surgery, because the disease is so extensive, they don't have a distal landing zone for their bypass grafts. And then to find a good vein graft in these patients, because of multiple morbidities that these patients will have, becomes challenging for the treatment of these patients with surgery. When they do undergo surgery, that is bypass surgery, or if they get amputation, their wounds may not heal. Many of these patients have diabetes. So now we have taken away one disease and given them another disease where they will have to go to a wound care center for the whole year or maybe longer, and the wound just keeps on draining and becomes another problem. And 49% of patients had any diagnostic vascular evaluation prior to primary amputation, and that is the sad aspect. That many of these patients, if they would undergo diagnostic evaluation even before they develop CLI or after they had developed CLI, maybe we can save some of these legs, if not all of them. So a lot of amputations take place in the United States, and 82% of all amputations in the United States are due to vascular disease, and most of them involve the lower extremity. And the risk of major amputation is increased significantly when total occlusion is present in the popliteal and infrapopliteal arteries. And that is my reason of these vessels, when they get significantly stenosed, that is 90% or 99%, that it should be addressed, because when it gets totally occluded, it's going to cause bigger problems, which may be hard to. This is a paper that was published in JACC last year, where they look at just the Medicare database. So it doesn't include private insurances or outpatient centers. But what it shows is states that have higher amputation rates as compared to the national average. So you can see Georgia over here, 1.3 to 2.07, much higher than the national average. And you can see a lot of amputations taking place in these southern states. There may be more atherosclerosis, but they were not able to, in this article, identify why this is the trend, but they definitely saw this trend taking place. Interestingly, with all these regions, and I apologize for these regions not seen, the big thing I wanted to show in this slide was that the amputation rate is going down over a period of time. This was from 2000 to 2008. In all these states, even with high amputation rates, they is coming down. And interestingly, when you look at the data, what happens to these patients with below knee amputations? This is not above knee, this is below knee amputations. Well, 60% will undergo healing early on. But after 2 years, full mobility is only present in 40%. So even after amputation, that does not solve their problem. A large number of these patients will keep on having problems. A third will be dead, and another third will either have contralateral amputation or will undergo above-knee amputation because the wound wasn't healing. So this is disease which, if it could have been picked up 5 years earlier, we may have stopped it from progressing this badly. And when we look at critical limb ischemia, majority of the patients will present with multivessel disease, unfortunately. And that is involving the iliacs, the superficial femoral artery, and the tibial vessels. And it becomes a nightmare to treat because now you have to treat from inflow down to the distal runoff. There's no use treating this blockage and leaving this disease here. And there's no use treating iliac artery disease, which I see some physicians doing because it's easy to do it, but not treating the disease further down. Because if you don't have good runoff to the foot, the wounds are not going to heal. So most of the critical limb ischemia will present. Now sometimes we will see critical limb ischemia like the MRA I showed, where the disease is going to be in the SFA and the popliteal, just affecting this area, and the iliacs are spared. And occasionally we'll see disease when they have significant iliac stenosis. This I see more in younger people, like in their 40s, who will come in with severe iliac artery disease, and they will have a wound on their toes which is not healing, and that is a very simple case to take care of. Unfortunately, most of the time we are stuck with this type 3 disease where it's extensive, going all the way down into the foot. The current standard of treatment for peripheral occlusion has been surgery, and this was TASC. This was a committee which was in 2000 first they formed, and then they came with 2B recommendations because they realized that the devices were getting improved, and that has become now almost obsolete because that came out in 2008. And we are treating many lesions. But they left this thing in the TASC recommendation that it depends on centers and it depends on expertise in those centers. If those physicians feel comfortable in doing endovascular procedures and complex lesions, then that may be the choice. And that needs to be discussed with the patient. Now, if the patient says that he wants surgery, many of these patients who can't have bypass surgery, the only option left would be an amputation. And when they do undergo bypass, it has significant morbidity. 30% of these patients will suffer morbidity either due to neuropraxis, that is nerve damage, or poor wound healing, and that becomes a problem for the patient. And many of these patients are unsuitable for bypass. Now, this was an interesting trend that was seen, published in 2009, that if you look at the endovascular interventions, they started taking off when the devices started becoming more, improved, and more physicians started doing endovascular procedures in early 2000. When that took off, the amputation rate and the bypass rate dropped. Now, will this trend keep on happening? I think unless we start identifying these patients early on, I don't think so. This is going to go away, the amputation. But it was interesting to see when the endovascular procedures took off because this wasn't a change in bypass surgery. In fact, bypass surgery went down. And when you look at the devices that became more available, in 2003, the first atherectomy device for the lower extremity became available. And we were early on and started doing it. Atherectomy took off, angioplasty took off, which includes stenting and laser and cryotherapy. But the total endovascular interventions, they just took off. And now with newer devices coming, and very exciting trial that some of which we are in part of it. We will talk about that in a minute. I think the more and more endovascular procedures will be done as long as people are well trained and they can do it with safety. And what's the trend of endovascular procedures by specialty? This was data from 96 to 2006, and I think if they look at the data now in the past, even up to 2012, this has probably changed. Mostly cardiologists and vascular surgeons are doing these procedures. The radiologists who were really doing it early on, before in the 90s, they have just become too busy with other things. But cardiologists have picked up the ball, and the vascular surgeon, they made it mandatory in the fellowship in 2005 that all vascular surgeon fellows had to be trained for 1 year in endovascular medicine, which was a smart move, so now they can get some endovascular skills. But those are the two specialties that are basically confronting this challenge. So what are the treatment options? Well, we talked about surgical bypass. However, endovascular treatment is becoming the first line of treatment, even among vascular surgeons when medical therapy fails. And there are many options in endovascular treatment strategy. This is just a summary slide because the problem has been when you look at the older trials done in the 90s or early 2000s of balloon angioplasty, you will see in peripheral they talk about primary patency and secondary patency. In coronaries, we talk the secondary stuff as restenosis. But they don't want to talk about after primary angioplasty, the restenosis. They want to talk about restenosis after 2 attempts have been done. So they talk about primary patency and secondary patency. The more recent trials that have been done in the past 4 to 5 years, they are going the coronary way, that is primary patency. What is the restenosis rate of different technologies? And when you look at balloon angioplasty, the rate ranges anywhere from 30 to 60% is the patency rate at the end of 12 months. And if you look at stents, which have improved tremendously, because the earlier stents had problems with stent fractures, which really caused severe restenosis. We just had a patient who had developed this problem, and those patients are very challenging to treat. But stents range anywhere from 63 to 87% patency at the end of 12 months. If you look at atherectomy, and definitive LE was a trial where we were part of it, 800 plus patients were looked into this thing with arterial duplex, so they did not have an angiogram. And they showed that the 12-month patency with the atherectomy, when done by experienced people, can be anywhere from 74 to 84%. The problem that is becoming is that because of the way the government has made the decision of reimbursing for these peripheral procedures, a lot of outpatient labs are becoming popping up everywhere. And in fact, in Atlanta, in the next 6 months, there will be 3 labs opening. Because I was contacted by 2 of these lab people. And so they are going to be setting it up in different areas. Johns Creek is one area, one is going to be in Midtown, and one I think is going to be on the south side, where they will be doing outpatient interventions. And the sad part is, when these patients come for outpatient interventions, if they just do a balloon in the leg, they get paid somewhere by government around $8,000. If they do an atherectomy and a balloon, they get paid somewhere around $15,000 to $18,000. So people can be just putting an atherectomy device, whether they're competent or not, take it out, document that they have opened an atherectomy device, and go back with a balloon and treat those patients and send them home the same day. There was an outpatient center on Peachtree which has closed, and a few years back we saw a few of their complications ending up in the hospital. And unfortunately, that's the way the government has gone to control the cost, that make it outpatient centers. Once more procedures are done in outpatient centers, then they can bring down the costs in those outpatient centers, because hospitals, government is having a hard time fighting them. But anyhow, so definitive LE was the trial that was just finished last year and showed us the patency rate. And then the drug-coated stent got approved. The first drug-coated stent in the States got approved earlier this year, and it is still in limited release, and it is coated with paclitaxel. And what they showed was that the patency rate was 83% at the end of 12 months. The question comes is that if you have patency rates with stents, atherectomies, and drug-coated stents in the 80s, can we do something even better? Or can we change the technology and make it even simpler? When you look at surgical bypass, and if you look at the aortobiofem, well, those are large vessels, and their patency, 5-year patency, is really good. But as soon as you start coming to fem-pop below the knee vein graft or fem-pop below the knee prosthetic grafts, patency rate is dismal. So once you go below the knee with a bypass graft hooked up to a common femoral artery and popliteal below the knee or even further down, the patency rates become very dismal. And the problem is that if you have used a vein one time, you can't use the same vein. You will have to go to PTFE material like of a tube, and those don't stay open. So that's why my suggestion is, why not first try endovascular? And with the technology and the expertise, if they are not successful, then go for bypass. Now in aortofem, I have a lower threshold for sending them for bypass. So if they have the distal aorta is occluded and the iliacs are occluded, I will probably send them for aortobiofem because the patency rates are good. But as soon as we go below the inguinal ligament, the patency rates of these bypass grafts is not that great. And when you look at the vein graft versus PTFE, PTFE definitely does not play good. And when you look at a vein graft above the knee versus below the knee, the above the knee does better 5-year as compared to below the knee. So those are some of the things to think about when you refer these patients. Then in 2008, people started looking at drug-coated balloons. And there was a Thunder trial, which was published in New England Journal of Medicine, and then there was a FACC trial that was published in Circulation. Small numbers, talking about in the Thunder trial, there were about 50 patients in each arm. They had an arm with plain balloon angioplasty. They had an arm where the balloon was coated with the paclitaxel. And then they had an arm where they took the balloon and they dipped in a solution of paclitaxel and went in the body. And they looked at those. I won't go into all the details, but just to show you enough, that piqued the interest of scientists that why not have drug-coated balloons, since the patency rate, restenosis rates are really improved by using drug-coated balloons in the lower extremities. Remember, when we are treating these lower extremity disease, it's not a 5 millimeter or 10 millimeter or even 20 millimeter disease. We are talking 5, 10, 20 centimeter long disease. So putting long stents, we want to avoid if we can, because once the stents start shutting down, our options become very limited. So we'll switch over to veins, but when you laugh at your own mistakes, it can lengthen your life. But if you laugh at your wife's mistakes, it can shorten your life. Okay. So when I see patients, we have got these special disposable shorts that every new patient is given to wear them, so we can at least look at their legs. And many times you'll be able to diagnose venous disease by this classic pigmentation that you see. And this is the iron deposition that takes place because in venous disease, the blood that stagnates down, the red cells break down and release the iron, which starts giving this pigmentation. And if it goes on for longer, there's profound scarring that takes place in the skin because an iron is an irritant, and the skin gets thick and becomes like a pudy orange called lipodermatosclerosis. And venous disease is very, very common. I mean, even people sitting in this room will find that they probably have symptoms of this venous disease. And unfortunately, it gets missed a lot of time. So more people in US will miss productive work time due to vein problems than from artery problems, because when they get up in the morning, they just can't walk around, their legs are hurting. And the most common leg ulcer in wound care centers is venous stasis ulcer, not the diabetic ulcer as is commonly thought. And about 5% of US population suffers, somewhere 25 million people with this type of problem. And a lot of these go untreated. Only about less than 2 million seek treatment, but most of these patients go untreated. And the prevalence, as patients get older, above the age of 40, about 40% of women will have it, and 1/4 of the men will have it. And above the age of 60, 2/3 of women will have it, and close to half the men will suffer with this disease. And most of the risk factors are related to gender. In women, it's more common. Age, as the patients get older. Heredity plays a strong role. If a patient of mine says that so when I'm asking their family history, I'm not just asking for coronary artery disease or carotid disease or peripheral arterial disease. I also ask them if they have had venous disease in their parents, because if any one of them have it, the probability of them developing it is 92%. Pregnancy exacerbates it. And then there are certain professions like standing for long periods of time on hard surfaces. So I see in patients and flight attendants, hairdressers, waitresses, they will develop this thing. And obesity definitely plays a role in it. And if they've had any prior injury or trauma to their legs where they have had extensive surgery, for some reason these patients are at risk. And one of the thoughts is that during the recovery time, they had blood clots forming which destroyed the valves and they developed venous insufficiency. The symptoms of venous insufficiency, the most common one that I hear is leg fatigue or tiredness at the end of the day. And if you ask them or their spouse that, how do they sit down in the evening? Oh, they always pop up their legs on an ottoman. They have to keep their legs elevated. And when you ask the patient, why do you do it? And they say, I don't know. It just makes my feel legs better. But leg swelling or ankle swelling, rings around their socks, cramping at nighttime, severe cramping. I'm not talking of occasional cramps here and there. This is daily severe cramping where the patient will be in tears or will have to stand up and walk around because the cramps are so severe. Skin discoloration, we already talked about. The texture, the skin gets thick. And open wounds or sores, that's the late stage. And this is one of the most gratifying disease to treat because when you treat the venous insufficiency, the wound heals up. And the patients are delighted because they have usually had these wounds for months and they slowly heal up and then they come back again, unless you treat the underlying cause. 30% of restless legs can be due to venous insufficiency. And they think there's a gene of restless legs and of venous insufficiency close together, and that's how they may be linked. And a certain number of patients will develop obvious varicose veins, but not everybody will develop obvious varicose veins. A little bit about the anatomy, because as cardiologist, I wasn't too aware of this unless I delved into the venous disease. If you think of the leg as a circle, in the center runs the bone, and the bone is surrounded by thick muscle, and outside the thick muscle is thin skin. There are two sets of veins that drain our legs. One that runs deep in the muscle called the deep veins, and the other veins that run outside the muscle, underneath the skin, called the superficial veins. So one of the deep vein system is from the soleal and the posterior tibial. They join, form the popliteal vein, and then they form the femoral vein. It's not called any more superficial femoral vein. The nomenclature changed in 2001, but people still, I see, use it because it's not a superficial, it's really a deep vein, but it travels next to the superficial femoral artery. So in the old time, they used to call it superficial femoral vein, but it's really the femoral vein, which comes up and then joins the up over here with the deep femoral vein, and then forms the common femoral and the iliac veins. If you look at the superficial venous system, one is on the medial aspect from the medial malleolus, the anterior and posterior division of the great saphenous veins, which goes all the way up to the groin and joins with the femoral vein to form the common femoral vein and continues into the iliac. So this is a superficial vein on the medial aspect, and majority of the time this is the vein which is the culprit. And it gives branches, anterior, accessory, and posterior, and sometimes when this vein gets diseased, these are the branches that you will see as varicose veins running across the thigh. And then there's another superficial venous system which is behind the calf, which is called the small saphenous vein. In the past, they used to call it the lesser saphenous vein, but they don't use that terminology anymore, which starts from the lateral malleolus and comes in and joins the popliteal vein in the popliteal fossa, and can have a cranial extension, and sometimes it can wrap around and join into the great saphenous veins. There's a lot of vein anatomy variation, which makes it challenging in the treatment of this vein disease. So, as we all know, the venous blood flows from the capillaries to the heart, and the muscular compression of the compartments, the negative intrathoracic pressure, and the calf muscle pump, they all help with the vein circulation from the lower extremities. It is a low flow and a low pressure system. And in the past, the thought was that because of the pressure building up, the veins would dilate and the valves will come apart, and that's why you will develop this disease. The latest is that it's chronic inflammation of these valves which destroys them. And that's how the genetics may play a role. And once these valves get shriveled up, then reflux takes place and the pressure goes up. They develop venous hypertension and the vein starts dilating. So it is a progressive disease, and if left untreated, it does get worse over time. And some of the manifestations of this disease are varicose veins. You can see pigmentation of the legs, or you can see late stages of ulceration with classic pigmentation and lipodermatosclerosis of the skin taking place. So most of this is venous hypertension due to reflux, but you can have outflow obstruction, that is iliac vein occlusion. You have the May-Thurner syndrome there, and then you can also have failure of calf muscle pump. People who are bedridden for long periods of time or who cannot walk around, don't use the calf muscle pump, they can also develop this disease. So chronic venous insufficiency is diagnosed by a venous Doppler. It is again very technician dependent. When you send these patients to radiology or hospitals, the test is done lying down. 70% of this disease will not be diagnosed if the test is done lying down, because most radiology places are looking for DVT, they are not looking for chronic venous insufficiency. What we do is we are looking for reflux. We not only look for reflux, that is blood coming back when we squeeze their calf, but we also measure the time, because normal is less than 0.5 seconds. Once the reflux time gets greater than 3 seconds, we start thinking of treatment. And in those patients, if they have ulcer or dermatitis, then our threshold for treating is early. And treatment is ablation in those patients. And if you have deep vein reflux, really, there's only treatment is compression stockings. There's no treatment yet. They are experimenting with implanting valves in the deep veins, but right now it is in the animal stage. And if there's no reflux, you can still give them compression stocking. For some reason, these patients will get the benefit. And normally, these should be thigh high and not knee high. But for traveling knee high in patients who don't have the disease is fine. And this is how the vein looks on ultrasound. So the skin is right here. This is 1 centimeter deep. This is the saphenous sheath, which splits where the vein is, and then it joins on the side. And below the saphenous sheath is the muscular compartment. So it's very easy to see these veins under ultrasound. The conservative treatment for vein disease is exercise, leg elevation, and compression stockings. And when the disease gets really bad with wounds, they can have Una boots, which are compression boots placed on their up to the knees. They only treat the symptoms but not the underlying cause. The surgical treatment in the old time was vein stripping and ligation, which I almost think has become obsolete because of its painful nature and takes 6 to 8 weeks to recover. More commonly, endovenous ablation is done with either radiofrequency or laser. And the ultrasound diagnostic study is really pivotal to, before you do the treatment, you want to make sure the deep venous system is patent. You don't want to shut down a superficial vein system and they have got chronic DVT, because then you will have a problem in these patients. Radiofrequency, I will skip. This was a patient that we had treated, and in 8 weeks' time, the wound had healed up. The pigmentation, unfortunately, fades but never goes away. So I tell patients it's like a tattoo, which will never go away for the rest of their life. And there are many ways of following these patients. You can follow their pain, the varicosities, the edema, and over a period of time, they improve. So they've made the scoring system, the venous classification in following these patients. These are some of the references. Thank you very much.
Thank you for that very comprehensive overview. We'll open it up for questions for a few minutes. I'll start with one. In your initial algorithm for evaluation, you said patients with 0.7, I think, to 1.3 ABI, you would still, was that all patients then that you would move on with an exercise ABI, or is that just those that are symptomatic that you take to that next step? Because that
So
certainly
we will do an exercise ABI even if they're asymptomatic. The symptoms becomes a problem. Unless we make them walk on a treadmill, we are not sure are they really asymptomatic or not. So what we do is we do an exercise ABI, we look at their symptoms and we look at the numbers. Now if they start having pain when they're walking and the ABI still is normal and the arterial waveforms are normal, then we tell them this is probably not vascular, this is something else.
Dan? Dan, we got to use the microphone.
I'd like to ask, what is the cost of the ABI?
So the insurance company pays anywhere between $80 to $110 for an ABI. And doing the ABI, the machines these days, cost of these machines have come down to like $3,000 to $5,000. But if you want a little fancy machine, you can go even up to $7,000, $8,000 for a machine.
No, I mean, I'm asking this because, I mean, from what you're saying, and we know that is why we don't do this in every patient who comes to our clinic, you know, I mean, like a blood pressure, or at least to do it in patients who have like diabetes and risk factors, you know, if we can save downstream, you know, so much money, why we don't, or is there a cost-effectiveness study to done in this? But I mean, I guess you don't in cost-effectiveness study. I mean, it's obvious that.
That's a great question, because Medicare will reimburse you if you do ABI and if it comes back abnormal, even if they're asymptomatic. However, if you are doing screening ABIs above the age of 50, they will not pay you if the ABI is normal and the patient was asymptomatic. However, if the patient is complaining of symptoms and you do an ABI and it comes normal, they will pay you.
I mean, we, as you say, you know, most of the patients are asymptomatic because they don't express symptoms because they change the lifestyle. So
either change the lifestyle or we don't ask them. So if we don't ask them and document it and we order an ABI and it comes back normal, then the reimbursement won't be there. But if we have documented symptoms that the patient is walking slowly, complains of leg fatigue or leg discomfort, we do an ABI, that will get reimbursed whether it's normal or abnormal. But Stan, I completely agree. Just like we do blood pressure check, should an ABI become, with the newer machines, it may become easier. In the past, the problem was with the handheld Dopplers. If the Doppler just moved on the dorsalis pedis artery just a few millimeters, you will not hear the sound, and your ankle pressure may be artificially recorded low. That's the.
Would you comment on the benefit that may be conferred from intense lipid lowering?
So all the recommendations are that these patients who have got atherosclerosis in the legs should be treated aggressively with lipid lowering, blood pressure control, and hemoglobin A1C control. Are there any trials that have prospectively looked at this thing? No. But they all think that in treatment of atherosclerosis, just aggressively treating these would be a good idea. There's no data that in endovascular treatment where patients have been looked at for aggressive lipid lowering versus no lipid lowering didn't make an impact.
Two questions. One, how long do you leave patients on Plavix when they've had a stent? And number two, what pressure do you order for the compression hose?
So Plavix, again, there's no data after endovascular procedures. There are some people in the old time radiologists, when they used to do balloon angioplasties, they used to just use aspirin. At that time, Plavix was not available. And in large vessels, in iliacs and subclavians, you may not even need the Plavix. I personally use it for at least 3 months. If they have below the knee disease that I've treated, I will go longer, because there have been studies that have compared in medical management of peripheral arterial disease, aspirin versus clopidogrel, and they've shown that just clopidogrel did help these patients in when they were medically managed. But after device use, whether it's a stent or whether it's a balloon or atherectomy, any device, I just give them for 3 months, but not based on any science. The second question of compression stockings. So you really have to, if they have disease, if they have venous insufficiency, then you really need to use therapeutic compression stockings, which are 20 to 30 millimeters of mercury. So thigh high, 30, 20 millimeters. If the patient is elderly and they have problem putting these stockings on, then I think 15, 20 would be fine. But ideally 20, 30. Even after treatment, we use 20, 30. Now there are some folks who will use 30, 40, but they're extremely tight, very hard to put on. Even some of my patients with 20-30 complain, but they should be thigh high, knee high really don't have a value. And in obese patients, you really have to go to pantyhose, because the thigh high will roll down over while they're wearing it during the day. Spencer.
I enjoy that very much, but I want to be clear on your recommendation for asymptomatic patients and what sounded like prophylactic intervention in asymptomatic patients. I was unclear when that should ever be recommended.
So in asymptomatic patients who have an ABI of less than 0.7, if the MRA shows significant disease, and I imply, like something 90% or greater stenosis, my view is that they should be treated. Because when that becomes 100%, then it becomes a nightmare for us to treat that blockage.
But that sounds a bit like in the coronary that we should treat all stenoses that are significant to prevent progression or something, and we haven't been able to show that. That affected a trial of that strategy to really convince all of us.
The problem with the peripheral trials, and same as with coronary trials, is that as soon as a trial is finished, that technology that was used has become obsolete. So people then start talking about, so when the balloon trials were getting done, like the basal trial, which was done in Europe, where they looked at surgical bypass versus balloon angioplasty in the lower extremities, and they showed that the 12 months patency rates were very similar in those two strategies. People came back and they said, but who does balloon anymore in the legs? They are doing stents and they are doing atherectomy. By the time we finish these trials, people are going to come back and they say, who does these trials? People are using drug-coated mechanism. So right now, we are doing a drug-coated balloon trial. We just enrolled our second patient in the SFA. Is that going to have an impact? But your point is very cogent. Just like in coronaries, we only showed that there was symptomatic relief in patients, when we did, but we didn't affect their longevity. I think the same thing is going to come and ask us this question in lower extremities. I mean, is there something are we doing it and can we manage this medically? Because it's happening in carotid. Because after the battle of carotid stenting and carotid endarterectomy, now people are asking in asymptomatic carotid disease, is there a good trial comparing optimal medical management? And there's no really good trial. So now a trial has to be designed comparing optimal medical management versus carotid stenting or versus carotid endarterectomy in asymptomatic patients. And the same thing, I think, Spencer, you're right, will need to be done in the legs.
So are there any registry data like the NCDR to try to collect data? I mean, it's obviously challenging with multiple specialties are involved, but it seems to me that to get an understanding of the landscape of what percentage of SFAs or some standard lesion is treated percutaneously versus surgically, to understand where the equipoise is, and then to help design a trial. I mean, I think this area is really devoid of trials, and the argument that the technology becomes obsolete is an argument that exists in all beds. So I think, what are your thoughts on that, especially with the drug-eluting balloons?
Yeah, there's no national registry that does it. It's company-based, and that has their own biases. They have their own registries for their own devices. But there's really no national registry that everybody is sending their cases, just like in coronary disease. And it will be great if that can be formed, because we can look at that data. But right now, I'm not aware of it.
With that, well, thank you very much for a great talk, and I appreciate you.
The preceding program is copyrighted by Emory University.